Hello students, this is Dr. Frances Munroe from the George Washington University School of Nursing, talking with you today about heart failure. This is part 2 in a series of lectures on heart failure, and today's presentation will deal with the management and treatment strategies for heart failure. First, I'd like to do a review of the Framingham diagnostic criteria for heart failure. The diagnosis requires the simultaneous presence of at least 2 of the major criteria or 1 major criteria in conjunction with 2 of the minor criteria. So what are some of the major criteria that you may use or see in your patient with heart failure? These include acute pulmonary edema, cardiomegaly, hepatojugular reflex, JVD, paroxysmal nocturnal dyspnea or orthopnea, the presence of rales during lung sounds, and a third heart sound gallop that you may hear during your cardiac exam. You may also notice increased central venous pressure and a weight loss greater than 4.5 kilograms in a 5-day period after the start of treatment. Some of the minor criteria used to diagnose heart failure would include bilateral ankle edema, the presence of dyspnea on exertion, a nocturnal cough, hepatomegaly, pleural effusion, a decrease in overall vital capacity, or the presence of tachycardia, which is defined as a heart rate greater than 120 beats per minute. The Framingham Heart Study criteria listed above are 100% sensitive and about 78% specific for identifying patients with definite heart failure. So let's recap what we learned in part 1 of the heart failure lecture, which was how to evaluate your patient who presents in the office in the outpatient setting for an initial evaluation of heart failure. You want to first take a complete history, conduct a very comprehensive physical exam, order your diagnostics including lab work, BNP testing, chest x-ray, 12-lead EKG, and then apply the Framingham criteria, checking to see if 2 of the major or 1 major and 2 minor criteria are met. If they are and you suspect heart failure, then go on to ask for the echocardiogram to be done. If not, then take a look at other alternative or reversible causes of heart disease and treat those. And if the Framingham criteria is not met, as we see on the far right of the screen, or you have a normal BNP level, then systolic heart failure is ruled out. And if you still suspect diastolic heart failure, then go ahead and get the 2D echocardiogram. Remember, if the ejection fraction is greater than or equal to 50%, you're going to diagnose the patient with diastolic heart failure. They may have elevated left atrial pressures, a decreased left ventricular compliance with impaired relaxation. And you would then use treatment strategies specific for diastolic heart failure. If the ejection fraction is less than 50%, then you would find the patient has systolic heart failure and you would treat that accordingly. Remembering to always consider a full evaluation for coronary artery disease, including referral to cardiology for stress testing and heart catheterization if needed. So what are some of the goals of the management of heart failure? Well, obviously we want to decrease the patient's clinical symptoms of shortness of breath, exercise intolerance, and fatigue. You definitely want to treat any secondary causes of heart failure, such as valvular heart disease or coronary artery disease. You want to reduce the risk factors that predispose your patient to heart failure, including diabetes, obesity, hypertension, and heart disease. You want to improve their heart function and increase their exercise capacity, slow the progression of heart disease, decrease the frequency and amount of hospitalizations, and improve overall mortality. You want to definitely prolong but with an improved quality of life for your patient. Specifically, let's take a look at some of the non-pharmacological treatments that you may institute for your patient with heart failure or at high risk. So first, you want to talk with your patient about sodium restriction, fluid balance management of their water intake. All patients with heart failure should receive extra dietary instruction regarding sodium intake, since dietary indiscretion is the most common cause of exacerbations of heart failure. You may want to refer your patient to a dietitian in order to get extra counseling to learn the need for fluid balance management, avoiding excess sodium and/or water intake. Sometimes sodium restriction alone can provide substantial benefits for your heart failure patients. And patients should call us after they take daily weights to detect any fluid retention. They need to call if they have a 2-pound or greater weight gain overnight or a 5-pound or greater weight gain in a 1-week period. Daily weights are very important for managing heart failure and the early detection of any shift in fluid retention. Next, you want to simplify their medication regime as much as possible. All medications, including over-the-counter medications, should be brought in to every single visit for you or the nurse to review. You would also consider a referral to cardiac rehabilitation to improve the exercise tolerance for your patient, and you may consider referral to a heart failure clinic for more specialized care. Again, we need to stress getting the patient and family involved with shared decision making and any type of education to help with compliance and end-of-life considerations. Let's take a look at the pharmacological management of heart failure. There are several classes of drugs that are very important. I've listed them all here in alphabetical order. These include the aldosterone antagonists such as spironolactone, ACE inhibitors, the angiotensin receptor blockers, also known as ARBs, the beta blockers, digoxin, hydralazine and nitrates, which are often used in combination, and the loop thiazide diuretics. Let's take a look specifically at the angiotensin converting enzyme inhibitors, also known as the ACE inhibitors. They are usually considered first-line therapy in patients with left ventricular ejection fraction less than 40%, and they are often used in combination with diuretics for the treatment of heart failure. They have been proven to show a reduced morbidity, mortality, and hospitalizations in patients with heart failure, and they are indicated for patients with all stages of heart failure when the ejection fraction has dropped below 40%. They produce vasodilation, both venous and arterial vasodilation, thereby reducing both preload and afterload, and they can help to decrease the myocardial remodeling that goes on with heart failure. Overall, they've been found to reduce morbidity and mortality rates by about 20%. This helps to reduce symptoms, and the use of ACE inhibitors also improve exercise tolerance, thereby preventing further and recurrent hospitalizations. Now, therapy with ACE inhibitors should be started at very low doses to prevent hypertension and titrate gradually to higher doses as tolerated. It is very important to monitor blood pressure, renal function, and potassium levels prior to starting therapy, 1 to 3 weeks after initiation of therapy, and then every 3 to 4 months thereafter. Some of the contraindications to the use of ACE inhibitors are renal insufficiency, which is defined as a creatinine clearance less than 30 mL per minute, the presence of renal artery stenosis, hyperkalemia, hypotension, or severe adverse reactions such as angioedema. Next, let's take a look at the aldosterone antagonists. This includes eplerenone or spironolactone, which is more common. This class of drugs has been shown to reduce mortality and hospitalizations in patients with heart failure. It's indicated mostly for heart failure patients with an ejection fraction less than or equal to 40%, often given post-MI, for patients who are already on the other standard therapies, including ACE inhibitors, beta blockers, diuretics, and or digoxin. Now, please keep in mind that spironolactone may cause hyperkalemia, gynecomastia, and galactorrhea, so it is important to monitor lab work. Creatinine should be less than or equal to 2.5 mg per dl in men and less than or equal to 2.0 mg per dl in women before you would start them on an aldosterone antagonist. Potassium levels should be monitored and less than 5.0 before starting the medication. There can be some very serious and life-threatening interactions and hyperkalemia or renal insufficiency with the addition of spironolactone, so it's very important to monitor lab work at baseline and then on a regular basis 3 to 7 days after starting the medication and every month for the first 3 months and quarterly thereafter. Angiotensin receptor blockers, also known as ARBs, also reduce morbidity, mortality, and hospitalizations in patients with heart failure. However, they are not usually used as first-line therapy for patients with heart failure because they have been found to be slightly less effective than the ACE inhibitors. So ARBs should primarily be used in patients who meet the same criteria for ACE inhibitor use, and that is the ejection fraction less than 40%. But for patients who cannot tolerate ACE inhibitor therapy, either due to minor side effects such as cough or major side effects such as angioedema. Again, you want to monitor blood pressure, renal function, and potassium levels prior to starting therapy, 1 to 3 weeks after the beginning of therapy, and every 3 to 4 months. They have a very similar contraindication profile as the ACE inhibitors, and you would never want to combine the ACEs, the ARBs, and the aldosterone antagonists due to the very harmful possibility of hyperkalemia. Next, let's take a look at the beta-adrenergic blockers, also known as beta blockers. Beta blockers are a very important drug treatment used in heart failure. They have been proven to reduce mortality, hospitalizations, and improve symptoms in patients with heart failure. They have often been used first line for symptomatic patients with left ventricular ejection fraction less than 40%, those patients with a history of ischemia, cardiomyopathy, MI, hypertension. They have been shown to reduce post-infarction mortality by 1/3, and they can reduce ejection fraction by up to 10% over a 3 to 6 month period. You would actually see a reduction in left ventricular size. The benefit is believed to be conferred by a blockade of the sympathetic effects of the neurohormonal stimulation due to heart failure. Beta blockers are indicated for stable symptomatic patients, and most beta blocker studies have been done in patients already taking an ACE, diuretic, and digoxin. Beta blockers are also very helpful for rate control in tachycardia-induced heart failure and are actually preferred over the other agents. Only carvedilol, bisoprolol, metoprolol long-acting have been approved for the medical treatment of chronic heart failure, and these agents are usually started at a very low dosage and slowly titrated upward as tolerated due to their side effects. Some of the adverse effects include worsening of heart failure due to the negative inotropic effects. Some patients notice a worsening of fatigue, dizziness, bradycardia, hypertension, and bronchospasm. Digoxin is another very important drug that is used to prevent the deterioration in heart failure patients with left ventricular dysfunction. Digoxin also helps to improve exercise tolerance, reduces symptoms and hospitalizations, however, does not affect any heart failure mortality rates. Digoxin is very useful in mild to moderate systolic heart failure. Those are the patients with an ejection fraction less than 40%. And it's also very useful in patients with heart failure who have atrial fibrillation with a rapid ventricular response. Many times used in combination with ACE inhibitors in helping to reduce hospitalization rates. So it's an add-on for mild to moderate heart failure in patients who are symptomatic that are already using ACE inhibitors and diuretics. However, again, you want to be very cautious in using it in patients with abnormal renal function to avoid toxicity and life-threatening arrhythmias. You want to monitor digoxin blood levels, usually within 5 to 7 days of starting therapy or changing a dose. If you suspect toxicity, if you suspect non-adherence, any new or existing renal function problems, and if you want to determine whether your patient is in a therapeutic range. At the same time, you want to continue to monitor your serum creatinine and electrolytes, recommended again at baseline and periodically thereafter. Diuretics can be very helpful in reducing the signs and symptoms of fluid overload in your patient with heart failure. These would include things like edema, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, or JVD. However, diuretics have not demonstrated a reduction in overall morbidity or mortality rates associated with heart failure. So it is not recommended that diuretics be the sole therapy used to treat heart failure. In the past, escalating doses of diuretics were considered the mainstay of heart failure therapy. But now we know that these high doses of loop diuretics can actually increase mortality through further activation of the renin-angiotensin-aldosterone system. The best loop diuretics to use are either torsemide or bumetanide. They are better but more expensive than Lasix. And again, it's very important to monitor lab work on a regular basis for patients taking loop thiazide diuretics, and that would include basal metabolic profile, including the electrolytes, BUN, serum creatinine, magnesium, calcium, fasting glucose, and even uric acid levels. It's very important that patients who have a history of gout be monitored for any worsening of their symptoms. They may not be able to tolerate the diuretic. Same thing with patients with diabetes. You want to check their glucose levels before they start the diuretic during the initial phase of treatment within the first few weeks, and then frequently thereafter, monitoring for any signs of worsening of their glycemic control. Hydralazine and the nitrates are another option for your patients with heart failure. They work by dilating the arteriolar smooth muscle and lower peripheral vascular resistance and afterload. The nitrates cause venous, and hydralazine is responsible for the arteriolar vasodilation. And as we mentioned, inpatient, the nitrates often used are IV nitroprusside or nitroglycerin, used for acute or severely decompensated heart failure patients. And the outpatient side, isosorbide is commonly prescribed in combination with hydralazine, which helps to increase cardiac output. Research has also shown that the combination of isosorbide and hydralazine is also better for patients who are African American with heart failure. Also, the combination of hydralazine and isosorbide can be useful to reduce morbidity or mortality in patients who cannot be given an ACE or an ARB because of a drug intolerance, hypotension, or renal insufficiency. Now remember that the adverse effect of nitrates can include hypotension, headaches, and tolerance, as well as reflex tachycardia and lupus-like syndrome with hydralazine. Another consideration for your patient with heart failure is the possibility of concomitant atrial fibrillation or cardiac arrhythmias. These are often present in up to 10 to 15% of all patients with heart failure. Most of these can be managed with digoxin alone, but some may need the addition of Coumadin and/or regular strength aspirin per day. Studies have shown that up to 70% of patients with heart failure have had some asymptomatic episodes of VTAC. This indicates an overall poorer prognosis, and you certainly want to consider the use of beta blockers, implantable defibrillators, and we don't see as much amiodarone as we have in the past. Let's also take a look at the evolution of heart failure and treatment strategies by different stages. The American Heart Association, American College of Cardiology came up with these stages of heart failure, A through D, and recommendations at each stage. To review, stage A would include your patients who have risk factors but are completely asymptomatic and have no evidence of any heart disease. These are patients with risk factors such as hypertension, hyperlipidemia, diabetes, aging, obesity, alcohol use, smoking, and family history. As we move along the continuum to stage B, we may see some patients who are starting to show some signs of structural heart disease but are still asymptomatic for heart failure. These patients may have left ventricular hypertrophy, history of MI, coronary artery disease, diabetes, and they may show some signs already of ventricular remodeling. Once we get to stages C and D, we do now have patients who are symptomatic with decreased exercise intolerance, worsening fatigue, shortness of breath, all due to ventricular dysfunction, whether it be systolic, diastolic, or both. So let's take a look specifically at the treatment of patients in stage A. Again, these are the patients who may have hypertension, heart disease, diabetes, and are generally at risk for developing heart failure, but are completely asymptomatic. The management of hypertension aggressively at this stage has been shown to reduce the risk of heart failure by almost 50%. Using ACE inhibitors first line is very important, and then adding diuretics will actually help to prevent heart failure. Aggressive treatment of hyperlipidemia with statins also reduces the risk of heart failure in these at-risk patients, and long-term treatment will also reduce the risk of developing heart failure. Other conditions that can lead to or contribute to heart failure include obesity, diabetes, tobacco use, lack of exercise, excessive alcohol intake, and these should all be controlled or avoided. Specifically, obesity has been repeatedly linked to an increased risk of heart failure, and diabetes is a very important risk factor for women and actually may triple their risk of developing heart failure. Dysglycemia appears to be directly related to risk, with A1C levels predicting the heart failure risk. Treatment in stage B is usually aimed at taking care of the underlying health problems that patients may have. Similar to patients with stage A, these patients in stage B need to maintain excellent control of their hypertension and hyperlipidemia. ACE inhibitors should be used to prevent symptomatic heart failure and reduce mortality. Many of these patients already have structural heart disease, and they may show signs already of left ventricular hypertrophy, have had a previous MI, and they may have asymptomatic valvular disease. We want to include all of the lifestyle measures we talked about in stage A, such as smoking cessation, increased exercise, healthy diet. We want to add ACE inhibitors or ARBs to prevent heart failure, add beta blockers in those patients who have a reduced ejection fraction, and most importantly, do not use calcium channel blockers, especially those that have a negative inotropic effect in patients with heart failure. Continue to treat lipid disorders aggressively, again to further reduce the risk of symptomatic heart failure and cardiovascular events. So in addition to interventions that we discussed for patients with stage A and B heart failure, patients who have stage C heart failure also require additional interventions because now they have symptoms of heart failure and they also have the underlying heart disease. Sometimes their symptoms will include shortness of breath, fatigue, decreased exercise tolerance. Patients need to be monitored for any history of fluid retention and any adverse effects from their medications such as electrolyte imbalances or dehydrations. You certainly want to encourage dietary salt restriction and using the medications as mentioned earlier, diuretics for fluid retention, ACE inhibitors and beta blockers, along with adding digoxin, hydralazine, and isosorbide. And lastly, using the aldosterone receptor antagonists. These are definitely indicated for patients at stage C, which corresponds to class 3 and 4 of the New York Heart Association recommendations. These patients should all be monitored for hyperkalemia and renal insufficiency as they are on combination medications. You would also want to talk to patients at this stage about the role of device therapy, including implantable cardioverter defibrillators and pacemakers. Treatment for stage D or class 4 heart failure often requires specialized interventions for your patient who has refractory heart failure and severe symptoms at rest. These patients often have advanced structural heart disease. They are frequently hospitalized for exacerbations. Many are in hospice or even awaiting transplantation. The annual mortality rate of systolic heart failure ranges from 10% in stable patients with mild symptoms to greater than 50% in patients with class 4 or stage D disease. Cardiac transplantation may be indicated for these patients, and it has a 5-year survival rate of around 70%. It can be a viable option in some of these patients. We certainly want to include all measures that we've discussed already in stages A, B, and C, and then we may want to discuss with patients the possibility of a permanent mechanical support, chronic inotrope therapy, or referral to a specialized heart failure clinic. The use of a left ventricular assist device is a possibility in patients with advanced heart failure, and it can result in clinically meaningful survival benefit and improve the quality of their life for patients who are not candidates for heart transplantation. And there are also some devices that are used as a bridge to transplant rather than destination therapy. Once again, it's very important to involve the patient and the family in these discussions regarding hospice care and end-of-life care. So what is our criteria for hospitalization of the patient who presents in your office with heart failure? First of all, if you see any clinical or EKG signs or evidence of acute ischemia or MI, that would indicate prompt hospitalization. If your patient has severe symptoms that are refractory to outpatient treatment, they should be readmitted. If they show signs of severe respiratory distress or pulmonary edema, thromboembolic complications such as DVT or PE, and if they have severe complications from other comorbidities such as uncontrolled diabetes, hyperkalemia, or renal failure. You certainly want to monitor for any signs of hypotension or syncopal episodes. And another criteria for hospitalization may include inadequate social support for outpatient management long term. So in summary, you would want to follow your patients with heart failure on a regular basis. Initially, it may be on a week-to-week basis, and then you can spread that out on a month-by-month basis until they are stable. You want to focus on optimal pharmacologic therapy and the prevention of any heart failure exacerbations and repeat hospitalizations. You want to make sure that you include family members in patient education, as these patients are often easily overwhelmed by the amount of information and the need to monitor their dietary sodium and fluid intake on a daily basis. Reminding the patient to call you if they have a weight gain greater than 2 pounds per day or 5 pounds per week. And last but not least, this diagnosis and condition requires a lot of really good communication between the primary care provider, the specialist, the heart failure clinic, and all the other interdisciplinary team members, including the dietitian, in order to help the patient for seamless diagnostic and therapeutic care. Thank you for your attention today.